Today I'm going to talk about comprehensive geriatric assessment, a topic I know very well. And what will be covered in this talk is something we call the 5 M's of geriatrics, what the various components of comprehensive geriatric assessment, or CGA as I'll refer to it through the next part of the talk. I'll then provide a case-based example of how one does comprehensive geriatric assessment with some of the screening assessments we use and an approach used. And thanks in advance, I want to say thank you to Miley Karras, who reviewed this and gave me the idea for the 5 M's, and Jordan Lake for helping me get this talk in shape. So these are the 5 M's of geriatrics. So one of the criticisms of geriatrics is that no one really knows what we do. And so one of the ways people have tried to make that accessible is to call it the 5 M's or the high 5. And through this talk, we'll be talking about these high 5, or the 5 M's, which is the matters most, mind, mobility, medications, and multi-complexity. And we'll use this framework to talk about comprehensive geriatric assessment. So these are the 5 M's in some detail. So the first is matters most, and really that's knowing and acting upon each person's own health outcome goals and care preferences. So it's sort of the advanced care planning, really person-centered health care choices. Number 2 is mind, and that's identifying and managing issues that are more common in older adults, like cognitive impairment, dementia, delirium. Depression isn't more common, but one of the ones that we do assess. Mobility, identifying impairments in gait and balance, implementing an individualized fall prevention program, and creating an environment that enables mobility. Medications, optimal prescribing, adjusting doses, more appropriate for older adults, deep prescribing to reduce polypharmacy, identifying and being aware of adverse medication effects and medication burden, and finally multi-complexity, which is identifying and managing multi-morbidity and complex psychosocial situations. As I learn more about HIV, I can see there's a lot of overlap between what we do and what you do in your everyday lives, so this will be more applying it just to the older population. So comprehensive geriatric assessment has been around for quite some time. Its concept is a multi-dimensional assessment to evaluate the 5 M's of geriatrics. They're made to develop a comprehensive plan for prevention, treatment, and rehabilitation. And the assessment often, if you're lucky, employs an interdisciplinary team and standardized instruments for assessment. So it can be done by one person if you have to. It can be done by 5 people if you're fortunate. It can take 1 hour if you need to. It can take several visits if you're able. So it can be variable what you do with this. Its components are these. So it's, again, comprehensive. So in half an hour, I'm going to be going through this relatively quickly. And so we'll start with it, with some of the tools that we use to assess the 5 M's. And in this talk, I'm not going to be able to go into detail about what the various tools are. It's really more just to show you examples of the ones we do use. So for cognitive impairment or dementia, the common screening tools we do use are the MiniCog, the MoCA, or Montreal Cognitive Assessment, and there's one specifically for HIV dementia, the International HIV Dementia Scale. For delirium, there's a short one called the A-Test. There's a longer one called the Confusion Assessment Method. For mobility, we're looking at both history for falls and evaluation of gait and balance. So there's a question that we use to assess whether someone's fallen. There's a test called the timed up and go, or TUG. And there's something we affectionately call the Tonetti Gait and Balance Test, named after one of the pioneers in geriatrics, Mary Tonetti. For medications, we identify polypharmacy and inappropriate drugs. The sort of hallmark for this has been the American Geriatrics Society Beers criteria. We'll talk a bit about that. And under what matters most, it's really one of the things we do is advanced care planning. There's many tools to address that. and websites to help you. Two of the ones listed here are Prepare for Your Care and the Conversation Project, and then there's a tool called the Pulse, or Physician Orders for Life-Sustaining Treatment. And finally, under multi-complexity, that's sort of a place where sort of everything else goes. And one of the things that we do as geriatricians is address function. And so to do that, we address and assess activities of daily living and instrumental activities of daily living. They'll describe those, as well as frailty, which in this community you guys have really been been pioneers in this regard with the VAX index, and also the Freed frailty phenotypes, another frailty measure. So we're going to start with a case. So Mr. Jones is a 60-year-old male. He's a former IV drug user. He's virally suppressed. He's been living with HIV for 25 years. His niece accompanies him to the visit, so you're presuming you're doing your comprehensive geriatric assessment. You know from his medical history that he has HIV, he has COPD, he has peripheral neuropathy, lipodystrophy, and he has insomnia. His medications include antiretroviral therapy. He's on a fluticasone inhaler for his COPD. He's on gabapentin for his peripheral neuropathy pain. He has zolpidem for sleep. He smokes marijuana a few times a week to reduce his pain. Beer's criteria lists medications. Just looking at that list includes zolpidem. It's to be avoided per this list as it increases one's risk for falls and delirium. If you look at the intersection of zolpidem plus gabapentin plus marijuana, you really have a much increased risk for falls and delirium, so that's one potential issue to address with him. The next thing we'd review in the typical case is the review of systems and social assessment. So some of the things that we want to pay particular attention to in older adults is hearing and vision, dentition, mood, memory, sleep, urinary symptoms, gait, balance, falls, sexual function, nutrition, pain. And for social history, we want to know their living circumstances, the extent or not of social support, and/or support with their ability to do their daily activities. So for him, he does report some memory loss. He's not sexually active or interested. He has had trouble sleeping for years. He admits to burning pain in his feet. He has low body mass index, but this is stable. He's had 2 falls in the past year. For social history, he's never been married, he has no partner or children, he lives alone in an apartment, his niece is supportive, he's been on disability for many years, he was a computer programmer, he's had 2 years of college, and his only substance used is marijuana. To assess neuropsychiatric and substance use, we do the MOCA on him. He scores 20 out of 30. The items he misses is trail making B, which is a measure of executive function, clock drawing, which is visuospatial function, short-term recall, which is memory, naming, and abstraction. So that's a lowish score. Normal is 25. His PHQ-2, which is depression screener, is 0, so he's not depressed. And his CAGE AIDS score, one of the measures you could do for substance abuse, is 0. So that's good. So an interim assessment then, for just trying to figure it out along the way, is that potential issues to address with him are management of his pain. So we identified Beer's criteria list, which are bad. He has insomnia, which again, he's treating with medications that are not ideal. He does have fall risk, which he's acknowledged he has had falls, and he has risk factors for falls, including the peripheral neuropathy, as well as the medications and cannabis. He has cognitive impairment, as he admits on his review of systems, as well as his MOCA score, and the medications, again, we've talked about, increase that don't help, I'm gonna say. And he has some safety issues because of his falls. He lives alone, and his cognitive impairment, where we might be concerned about his safety. So this is moving on to functional status assessment. This is sort of what we call the basic activities of daily living, and these are the 6. So they include really self-care activities. So people who can't do these are people that potentially could live in a nursing home setting if they don't have help. So they include bathing, dressing, getting to the toilet, transferring from bed to chair to standing, being continent of bowel and bladder, and being able to feed oneself. Instrumental activities of daily living are less well-defined in terms of what exactly is considered an IADL, but they include activities you need to remain independent in the community. So things like using the telephone, being able to shop, preparing meals, housekeeping, doing laundry, using public transportation or driving, taking medication, and handling finances. So these are things we always assess in older adults in our assessment. So in terms of Mr. Jones, he can do all his basic activities of daily living or self-care activities. He's still able to use the bus, but he's having some trouble with getting out regularly to do his shopping. We'd ask a few more questions about why that's so. He isn't able to keep his apartment as clean as before, and he's not completely sure about what medications he's taking. His niece has been handling his finances for about 6 months now, as he has forgotten to pay his utility bill in the past. So in this assessment, as you understand or what he has problems with, you'd ask further questions, get some information from his niece who's with him to figure out what is beneath this. Why is the reason he's having trouble with his IADLs? Moving on to mobility, this modified Tinetti gait and balance test. For the gait testing part, and including, we would ask him typically to stand up from a chair, watch him walk, watch him turn, come back, and sit down. And so in this test, we find that he needs to use his arms to rise from the chair, indicating that he has either pain or weakness in his legs. He has to lift his whole foot when he takes a step. His peripheral neuropathy causes that. He needs to take multiple steps when asked to turn around. Typically, we take just one or two, a pivot turn. That could be weakness and or the neuropathy. And he needs to use his arms to sit back down, again, weakness. In balance testing, with balance testing the Tinetti, we ask the person to stand with their feet next to each other, the feet sort of one just partially in front of the other, and then foot, toe to heel. So he's unable to put his feet sort of one partially in front of the other and toe to heel. So his balance is off. For the timed up and go, he takes 20 seconds to stand, walk 20 feet, turn, walk back and sit down. More than 15 seconds is a fail, so he's slow on the timed up and go. An increase, that number means he has an increased risk for falls. So moving on sort of the regular physical exam we do, we see again his body mass index is 18, which is on the low side. Other vital signs are fine. On his AT&T exam, only pertinent positives are listed. He has temporal wasting, facial fat loss, poor dentition, buffalo hump, so signs of the lipodystrophy as well as the he has poor dentition. He has reduced breath sounds, which is the physical finding one might see with COPD. He has reduced grip strength and he's unable to feel a monofilament on his feet. That would be testing for peripheral neuropathy. And for his extremities, he has callus on his feet. You can get that also with peripheral neuropathy. You can also see that in just normal aging. So moving on to add onto the interim assessment. So the new stuff is in white. So we see that he does have limitations in his instrumental activities of daily living. We're not sure if he's taking his medications as prescribed. So we're even more concerned about his safety, knowing more about his situation. He has a demonstrated increased risk for falls on his modified Tinetti and TUG. His physical exam is notable for evidence of lipodystrophy, COPD, peripheral neuropathy, and frailty. That's noted by the reduced grip strength and his BMI being low. So moving on to other areas of assessment, we assess prevention and then advanced care planning. So prevention, these are the typical things one would look for in an older adult. Hep B is something that's specific for HIV. I hope I've been comprehensive on the HIV front, but for the geriatric part, minus the Hep B, that's basically what we do recommend now. Shingrix, as you know, is the newest version of the zoster vaccine and is a killed virus. Advanced directives, we want to discuss goals and preferences. We want to ask them about goals for care just in general for their health care. We want to ask about whether they have a durable power of attorney for health care, which is a document that says, you know, if you are unable to make health care decisions for yourself, who would you want to make health care decisions for you, and encourage them to have had a discussion about what their goals would be for health care with that individual or individuals, and then consider completing a POLST form, which I'll talk about a bit more. So for Mr. Jones, his immunizations and other recommended health care maintenance is up to date. He doesn't exercise, he does wear seatbelts regularly, he does have a durable power of attorney for health care, and his niece is his agent. So moving on to, again, further assessment. So the white is new. So we know on top of this that he has, again, no exercise, he has no POLST, and he needs a discussion of what matters. So the physician orders for life-sustaining treatment, I'll just talk a minute about here, is a form that has three main components. The first is, does the person want to receive CPR, cardiopulmonary resuscitation or not? And you say yes or no. And then the next section is, do you want to receive full treatment? If you said yes to that, or limited treatment. Limited treatment means you might not, God, I'm forgetting some of the details of this, I have to remember, but, and then if you don't want to receive limited treatment, you know, do you want to be sent to the hospital or not? And then you can also, the third part is about artificial nutrition and hydration. Do you want a limited trial of that? Do you want no trial of that? Or do you want full trial of that? And then you sign. Okay, then, so we've done the assessment, and now we're trying to figure out what to do. And so a plan of action could be to recommend that he stop smoking the marijuana to protect his lungs and his brain. We might consider adjusting his gabapentin dosing to better address his pain. We might want to add a topical treatment for peripheral neuropathy like capsaicin instead of a systemic treatment for peripheral neuropathy. For insomnia, we would try to get rid of the zolpidem by tapering it or stopping it. We would want to talk a bit about why he's having trouble sleeping. Is it because he's in pain? Is it because he's having to urinate in the middle of the night, which is a common scenario in older men especially? Do we want to try giving him melatonin instead of zolpidem? Do we want to consider sleep hygiene? Dare I suggest cognitive behavioral therapy for insomnia would be amazing. So those are some options for insomnia. Fall risk, we certainly want to adjust his medications to reduce that risk. We'd recommend that he does get physical therapy, assessment, and treatment to improve his strength, and to consider prescribing an assistive device like a cane and/or a walker if needed, at least temporarily until he gets stronger, if he can get stronger. We'd want to discuss his trying to implement an exercise program. We know more and more, of course, that exercise is good for your brain and your body, so we try to encourage him to do that. And then for cognitive impairment, we'd adjust his medications as previously noted. We might refer him for a more complete assessment to see whether he might truly have a dementia. We could ask the niece if she could supervise his medication administration, at least temporarily, till something better potentially could be figured out. And then for safety, we'd want to get a social work or home health referral for assistance with his instrumental activities of daily living. We'd want to get some kind of safety assessment in the home to see what we could do to protect him. And then related to what matters, we'd give Mr. Jones and his niece information on prepareforyourcare.org would be one thing you could do, or the Conversation Project. They have information on both the sites that you can print and give out, or send them to the website to go through, and then you'd follow up with that on the next visit. So begin that conversation. So to share the plan of action with Mr. Jones and his niece, you'd review your assessment findings and concerns. You'd use a shared decision-making approach to prioritize the next steps. You'd give them written information and instructions, and then make follow-up visitor visits to review and reassess your plan and finish your evaluation if necessary, and then make referrals as necessary for the individual. And then to finish up again, I just want to remind you of the 5 M's of geriatrics. Again, we have the matters most: mind, mobility, medications, and multi-complexity. This is a relatively new idea, actually, even to me, this format, but I like it more and more. It does seem to make sense, and it's accessible. So in conclusion, geriatric assessment is a means of assessing the 5 M's of geriatrics. The particular method that you use really can be individualized to your practice and circumstance. Another resource for geriatrics content and assessment tools is available through the American Geriatrics Society, and it's called Geriatrics at Your Fingertips. It's a booklet, it's an app, it's an online resource that you can have for like $25 or so. And then these individual tools, which you can get from the presentation, are also available, all of them. So anyway, thank you very much for having me today. I very much appreciate being invited here. And if you will have more questions for me, here's my contact information. Thank you.